Good morning, good day, good evening, everyone, wherever you are around the world and whatever your time zone is. I am Eva Bezak and I am Vice President of the IOMP and moderator for today's webinar. It is my pleasure to introduce our speaker, Professor Alexandru Dasu from Sweden. But before I formally introduce him, I would like to remind you to put your questions and answers into the Q&A tab of the Zoom, and I will moderate the discussion following the presentations. The presentations will be recorded, and you can watch the recording at your own time. The slides will not be forwarded to anyone. Also, please note that the full attendance of this webinar attracts one CPD or CME point, and this could be downloaded tomorrow from the IOMP website /certificates. Without much ado, it is my pleasure today to welcome Professor Alexandru Dasu to present today's webinar. Professor Dasu is a chief physicist at the Skandion clinic in Sweden with the long history of radiation biology, radiation oncology, medical physics, and he was also at the establishment of the first proton facility in Sweden. He has a long career that spans clinics, education, and research with a large number of publications, presentations, and postgraduate student supervision. Today, he will be talking to us about a very important topic of quality assurance in radiation therapy. Over to you, Alexandru.
Thank you very much, Eva. Good evening, good afternoon, good morning, everyone. I'm very glad to be able to speak about quality assurance in radiotherapy. It's a very important topic. I thank very much Eva and IOMP for having this opportunity. I hope that after the presentation today, you should be able to understand the rationale for quality assurance, the relationship between quality assurance and quality controls, and the methodology for setting up a quality assurance program in radiation therapy. IAEA put among the roles and responsibilities of the medical physicist to ensure the safety and the quality of the diagnostic and therapeutic procedures. So a natural question would be, what is quality? And quality, it's a concept which emerged at about the Industrial Revolution or thereabouts, definitely when the manufacturing processes become complex and they involve several people and systems in the various stages of production, highlighting a need for standards and reproducibility in order to achieve a certain degree of excellence or superiority of the final product. Since these very beginnings, the concept has evolved, and nowadays it is associated with requirements and satisfaction. Consequently, there were also processes developed to measure and to ensure quality. In radiation therapy, we are not very much away from these concepts because, as the colleagues from the AAPM have defined a few years ago, quality in radiation therapy consists of the feature which meets the need of the patient, and that is the way of interpreting satisfaction in radiation therapy, and that is that we have a successful treatment. And then also a process which conforms with accepted standards of practice and specifications, and these are the requirements. And then there is also the freedoms from errors and mistake, but this is the safety aspect of radiation therapy. Now, in order to achieve quality, people are talking about managing quality. And in quality, there are several components. One of them is planning for the quality. A second one is the quality control, the quality assurance, and the fourth one is quality improvement. What I'll be focusing during the lecture today is the quality controls and the quality assurance that are relevant for radiation therapy. So what do these terms mean? What do they refer to? Quality assurance, in its most broad sense, it refers to the confidence that the desired level of quality is met. So, as the name says, assurance, it's assuring that we have the quality necessary. And this is the definition that comes from the AAPM Task Group 100 that looked into the quality management of radiation therapy processes. And then, in addition to the quality assurance, we have the quality controls, which are those procedures that force the desirable level of quality by measurements, by comparing the measurements with the desired values, and then having a plan to act if a difference is achieved. Not surprisingly, the European Directive 2013-59 came up with similar definitions, that quality assurance is the planned and systematic action that provide the adequate assurance that the system and the structure and the method and the procedure, they perform satisfactorily in compliance with agreed standards. And they define that quality controls are a part of quality assurance. And what are quality controls? Well, they are the set of operations which are intended to maintain or improve quality. And it includes monitoring, evaluation, and maintenance that is required on the parameters that could be defined and measured. Generalizing, similar definitions also came from the American Society for Quality, where they said that the quality assurance, it's the part of the quality management that provides confidence, and it relates on how a process is performed. And quality controls is it's a bit more the inspection aspect of quality management. And they also provide this very nice illustration that have quality control as a part of quality assurance. And by extension, one could think that the quality assurance is the set of controls or the quality controls that one performed and creates a net which ensures the safety and the quality and the excellence that is required in any type of process. Now, if we take a closer look at radiation therapy, it's a multidisciplinary, multi-step treatment modality. So we already have the multi-step aspect that also appeared in the beginnings of quality. And it uses complex equipment, complex techniques to deliver ionizing radiation, generally for cancer patients. Having a multi-step and a complex technique, what we have is a process in which we have several steps, and each step could be subject to constraints and variations. And these constraints and variations may affect the fine balance between delivering enough dose to the target while keeping the doses to normal tissues at acceptable levels. Again, if I refer to the European Directive on the use of ionizing radiation for medical purposes, they came up with an important statement regarding the role of quality assurance programs in radiotherapy, including the study of the risk of the radiotherapy, and also the need for the medical physicist to take responsibility for the evaluation of the dose delivered to the patient and other individuals. So we have a clear relationship between quality of radiation therapy and the delivered dose. So if I come here, how accurate should one be in radiation therapy? How accurate do we have to know, or we have to determine the dose in radiation therapy in order to ensure some quality? In order to answer this question, we have to think that the endpoint of clinical radiotherapy is the biological effect. Primarily, we need to deliver a certain dose to a tumor, for example, to achieve a certain probability of controlling that tumor. And actually, if we go one step further, we have to remember that in radiation therapy, we also have the risk to normal tissue from the inevitable irradiation of the normal tissues. And therefore, in radiation therapy, we have a twofold requirements in accuracy. First, and primarily, towards the controlling the tumor, and then not to damage the normal tissues of the patient, and therefore to worsen their quality of life. Therefore, in radiotherapy, if we are referring to accident or misadministration of those, we have a double aim or a double aspect or a double requirement. We refer either to an underdose or an overdose. Both are equally damaging. One of them, for example, underdose, we fail to control the tumor, or an overdose means that we are damaging the normal tissue and we are inducing a high probability of a complication. And this differs in radiation therapy in comparison to conventional radiation protection or most of the other radiation protection legislation or protocols, where the focus is on overdoses. So we have this double standard, if we want to call it like that, on the requirements in radiation therapy, that we should deliver enough dose to the tumor, but not very high dose to the normal tissues. So one of the first proposals in establishing quality goals in radiation therapy has been to link the uncertainties in dose delivery to an observable biological effect. And this is an idea that came 40 years ago to a professor in Stockholm, Sweden, who said that actually whatever uncertainty in dose delivery you have, that should not lead to an observable biological effect, and therefore more or less to be interpreted as the normal noise in the process, in the radiation therapy process. And in order to do that, one has to look at the normalized slope of the dose response curve. And the normalized slope is defined as the change, the absolute change in percentage of the response divided by the relative change in dose. So let's say that if we're having 10% uncertainty or a 10% error in delivering the dose, what would that error or uncertainty mean in terms of probability of controlling or leading to a certain complication? And this is an analysis that has been done at that point in 1984, where Bramme has looked at what is the allowed uncertainty in dose delivery in order to have a certain variation in terms of the probability of a biological effect. And at that time, and nothing changed since then actually, they have come up with the conclusion that a delta P, so an error in delivery of 5%, or actually up to 10%, they said, is not something that is going to be seen in the normal radiotherapy workflow of a normal or a conventional radiation therapy department. And looking at the gamma of the various dose response curves, one could establish what would be the allowed uncertainty in dose delivery if we're aiming for a certain uncertainty in terms of the biological response. And based on this and similar analysis, ICRU concluded that we need to have an uncertainty of about 5% in the delivery of absorbed dose to the target volume. This is interpreted as 1.5 or 2 standard deviations of the uncertainty in dose delivery, which, not surprisingly, it's in agreement with the original proposal of Bramme of having about 3 or 3.5% uncertainty, defined as 1 standard deviation. Now, this is where the 5% uncertainty in or the requirement for at most 5% uncertainty in delivery dose in order to have a good quality of the radiation therapy process. In general, if you have a simple process with a minimum number of parameters, you could decrease these uncertainties. However, the allowed uncertainty tends to increase for more complex treatment situations, or it puts more stringent requirements in order to achieve a very high treatment uncertainty. And in radiation therapy, we have several potential sources of error that could affect the dose delivery. And that could be, as this diagram from the Astro booklet number 10 shows, we have the patient setup and the patient anatomy that could influence the dose distribution. We have the calibration of the machine. We have the mechanical calibration of the machine. We have the calculation of the dose. We have the transfer of information. We have the bin data and so on. So taking into account the many steps in radiation therapy process that could influence the delivered dose, we need to have a rigorous inspection system that will ensure that the accurate doses have been delivered in each session and within the scheduled time, because all these aspects are important. So the next question would be, what should we check in order to ensure that we have this very stringent requirement in terms of the delivered dose? Well, this is where the challenges start, because if we design the QA, a QA system for an equipment or a procedure or a process, we do not know from the beginning what are the likely failures of the system. When a failure happens, it's always easy to say, oh, this is something that we should have checked. But this is not something that we know from the very beginning. Another idea would be, let's apply the method and equipment that we have always used. Yes, the problem is that method and equipment, which are designed for older or established technique, might not be suited for new treatment techniques. And therefore, in order to start a successful QA program, one needs to perform an analysis of the possible risks for failures and what are the consequences if those failures materialize. So one important part in the quality system is a risk analysis. And the risk analysis means to perform an analysis of the possible failure modes, and also to perform an analysis of the effects for the specific equipment, process, and the method that you want to do. And this is an example of how such an analysis could be done according to the American Society for Quality, where you have a certain process, and then you could think about potential failure modes. And this is where experienced participants would think about both how the system works, how the process works, what are the steps and the influence factors in it. And then they should think about what is the potential effects, what are the causes, what are the controls that could mitigate or minimize these causes, and so on. Now, part of this risk analysis process, what one does is classify the failure modes from the perspective of their occurrence. What is the frequency of their appearance, or the probability of their appearance? What is the severity of their consequences? And what is the probability of that particular failure to go undetected? So based on the occurrence, severity, and detectability, one calculates a so-called risk priority number, which is the product of all these factors. And naturally, based on the risk analysis, one identifies those failure modes which are most likely to have a high risk priority. And that means those that have to be checked or highlights the checks that have to be done, how often they have to be done in order to mitigate the failure and the consequences, as well as what is the potential of the checks as mitigation measure to reduce these risk priority numbers. So in a way, this process gives you an indication of what to measure, when to measure, and how important it is that you focus on one parameters in comparison to another one. So I said that you have to check and you have to compare the results of your measurement to a value, a desired or a reference value. And you have to think that quality assurance as a process generally starts when you define the desired technical specification for the equipment that you want to purchase. So it's very early into the process that you have to think about what you'd like that the equipment or what you'd like that the method that you are devising would perform in practice. And that in a way sets the stage for your process. It's always very difficult to go up afterwards. So if you, let's say, bought a system that doesn't have very brilliant technical specification, it's very difficult to make it a posteriori to perform better than it actually does. Now, after the procurement, and the installation of the equipment, you usually go through the acceptance. And at acceptance, you verify that the performance of the delivered equipment is or corresponds to the technical specifications that you put in the procurement. And actually, many of the reference values for the parameter that you are going to be checked are set during acceptance or the subsequent commissioning of the equipment. This is where you say, well, I want my equipment to continue performing at this particular level. Now, after you have said this, you perform regular controls, and they will ensure that the relevant parameters are within the desired tolerances or the recommended tolerances. So, quality assurance. Quality assurance in radiation therapy, it extends in several directions. It looks at the general equipment functionality, and here it includes dosimetry, imaging, and medical. It looks at the treatment planning system, system communication, patient-specific quality assurance, and there are also other quality assurance approaches. And I'm going to briefly name all this to get a feeling about how important or how deep they go. With respect to general equipment functionality, there are many recommendations that are available. Here I have listed a few that are rather famous from the American colleagues on the quality assurance for the various equipment or techniques in modern radiotherapy, robotic radiosurgery, Linacs, helical tomotherapy, gamma knife, or proton therapy. In general, I mean, if you are going to work or if you are already working in one of these fields, you have to look at the one that is particularly relevant for you. However, there is a red thread through all of them. With respect to general equipment functionality, they recommend to check the dosimetry, the imaging, the mechanical, and other safety checks. Dosimetry is that part of functionality which concerns the absolute absorbed dose and the relative dose distribution that are delivered by the machine. Imaging concerns the detection and the positioning of the target relative to the beam or the treatment beam. Mechanical concerns the positioning of the target relative to the beam. Usually, imaging and mechanical are considered together, although imaging, as you are going to see, it goes a little bit further than the actual imaging for treatment delivery. And then there are the other safety checks, which are equally important, which monitor the function of key equipment that ensure patient, staff, and visitor safety. And in this, it's mainly to look at the barriers and the interlocks for the system in order not to have an unintended irradiation. Now, regarding the general equipment functionality, there are various tests, and the frequency to which one should perform the test depends on the impact of the possible failures, the likelihood of the changes, and the speeds of the test. So if you have a test that takes 4 hours or more, is not something that should be recommended for every single day, but you might still want to have some simple and quick test which would highlight the relevant parameters. Now, the testing program for the general equipment functionality, they're usually divided into daily, weekly, monthly, and yearly checks. But in addition to this program checks, also tests should also be performed after interventions on the system, because depending on the intervention of the system, the output or the performance of the system might be affected. And if you remember from the very beginning, it is the responsibility of the medical physicist to ensure that there is a high quality in the delivered dose. The frequency of the test, there are these recommendations that are around, but they may be adjusted according to manufacturer recommendations, as well as when you start building a knowledge on the system, you could realize that the frequency of some tests has to be increased because you see that you have more errors on a certain part or a certain test, and therefore you want to ensure that you have a good performance, or you see that you do not have major drifts in some parameters, and therefore you could have a lower frequency in checking them in order to see that you still are within the tolerance parameters. To give you some examples, I don't know how clear they are, but these are some examples on the daily checks that are performed on a Linac to the left side and on a proton therapy machine on the right side. And as you see there are the symmetry, the mechanical, and the safety checks in both of them. And with respect to the output constancy, it's more or less the same, nevertheless, or irrespective of whether you are talking about photon treatment or about proton treatments. With respect to the mechanical accuracy, you see that if you have, for example, if you look to the left panel for the photon treatment, if you are looking for non-IMRT forms of treatment, you could have a rather high tolerance for the mechanical tests, whereas for more advanced form like IMRT or stereotactic treatments, you have to have lower and lower tolerances in order to ensure a high accuracy in those delivery. Example of monthly tests, again, you see that, for example, if you look at the dose output, you have a higher requirement for the monthly test, and that is because the monthly test, for example, in dosimetry, should be performed more carefully than you could afford to do every single morning. Imaging, there is a lot of imaging in modern radiation therapy. You have onboard imaging devices that you are using for checking the positioning of the patient. They are sometimes included in general equipment functionality checks, but you also have the CT scanners, you have the MR scanners, you have surface scanning equipment. All of these are used in order to ensure that the patient is correctly positioned during the treatment. There are not unexpected recommendations on all these aspects from the AAPM, which are very good. And if you work with this, I recommend that you read them and get inspiration about what could be achieved from a good radiation quality assurance in radiation therapy. If we're talking about imaging tests, what you have to check is the image quality, the contrast, the resolution that could be achieved, or the noise in your image, the calibration. This is especially important for proton therapy, where you have the range or the predicted range of the proton very much dependent on the Hounsfield unit of the machine. If you're talking about CT, as well as what is the delivered dose from the imaging modality, not in the least for the combined CT, which gives a significantly higher dose in comparison to planar imaging. Surface scanning, you have geometrical tests that you see that the isocenter or the predicted isocenter of the machine coincides with the isocenter of the surface scanning system. Then you have the tracking accuracy, and you check that the measured amplitude is equal, for example, with the real amplitude of the motion that you are supposed to check, especially important for gated types of treatment. In mechanical test, you have to ensure that all mechanical components of the system are within tolerances, or they move within the respective tolerance. And this is an image of our test for the patient positioning system or the treatment couch of the system, where we check that the isocentricity of the movement of the treatment couch is within the specification. We have similar tests for the gantry rotation accuracy and so on. You have to ensure that the mechanical parts of your system, they help you in positioning the patient with enough accuracy in the treatment beam. Treatment planning system, it's a central critical system in radiation therapy. So for a treatment planning system, you have to perform a regular, at least at every upgrade of the system, but also an upgrade of the IT system, where you have to check the data integrity and the configuration files, all the models that you are having, all the settings for your system, they have been preserved. You have to look at the CT calibration. The calibration curves are still there after the intervention. You have to look at the geometrical aspects. We are all talking about various volumes for the target and for the organs at risk, but these come up from a succession of points delineated on an image. And depending on the manufacturer, or even for the same manufacturer, there are algorithms that define the interpolation and actually the extrapolation of the delineations in the volume. And therefore, you have to check that you have more or less the same volumes for some structures as you go on, for example, through an upgrade or after a change in the system. Those calculation optimization, I don't have to stress very much why they are important. You have to calculate and you have to provide the same calculation accuracy. Optimization should lead to the same successful dose distribution or a very similar one, because in many cases, as you probably realize, optimization it's a rather stochastic process. And do not forget about the end-to-end test, which also tests the communication capabilities of the treatment planning system with the other systems that are relevant for treatment planning. And I have listed here 2 references which are important with respect to the quality assurance for the treatment planning system. Okay. I have done, the radiation therapy is one of the most digitized healthcare forms, and I have briefly gone into that when I mentioned the TPS. But in radiation therapy, one uses information from several systems, whether that is from a diagnosis, from a simulation system, whether you have the treatment planning system itself, you send everything to a treatment management system, you send the plans to the treatment machine, you get the treatment records and you put them. You have additional information from the image guidance systems and so on. Depending on the type of the clinic and the organization, you could have either each system with its own database, and then you are sending data from one database to another one, or that each system communicates with the central database, the image to the right. But then, nevertheless, whatever system you are going to have, you have to ensure that the communication between the systems or between the systems and the database works in the proper way. You could send the relevant data, you could retrieve the relevant data. The communication protocol performs very well. In this, you cannot be alone. You have to talk to your IT department or IT responsible to check the IT aspects of the data communication. But they are equally important as the dosimetry, because you do not want, for example, when you send the treatment file, to get a corruption somewhere, and, for example, the information regarding the MLC positions during the treatment are lost, and therefore there is a risk that you are delivering the whole treatment to the open fields. That is just an example. Now, if we go on, a central part of quality assurance in radiation therapy is a patient-specific quality assurance. And patient-specific quality assurance could be achieved through several methods. One that is most established is the independent dose calculation, which has started from calculations in slab geometry for the more simple forms of treatment, where you could do more or less a calculation on a sheet of paper based on tables, lookup tables and correction factors that you have carefully tabulated. And you could calculate whether, for example, the number of monitor units that you are going to deliver, it's reasonable or not. As treatment forms have developed, then independent dose calculation became more and more difficult to perform, and therefore there were other methods that were recommended and equally effective in use, and that is, for example, dose measurement, either in vivo in the patient or measurements in the phantom. However, as computation techniques have evolved, we see an increase again in independent dose calculation, but this time with advanced algorithms. Some of them are even Monte Carlo calculations. Again, there are some recommendations on some of this, which I recommend very warmly. In vivo dosimetry is a form of patient-specific QA that ensures that the delivered dose to the patient it's within the accepted tolerances. The independent dose calculation, they basically tell you how well your TPS or your prediction of the dose is. But in order to ensure that you have delivered the right dose, in vivo dosimetry has been for many, many years one established way of doing it, and apparently it's still going rather strong in Sweden, where the regulatory authority have warmly recommended it in the latest issue of the national regulations. EPID-based measurements, they have also found their use for advanced form of treatment like IMRT or VMAT, because they allowed a way of checking the capability of the LINAC to deliver the fluence or the recommended fluence from the TPS. Pre-treatment measurements in phantoms, they are a very effective way of measuring the dose distribution, and this is something that we are using very much in proton therapy. However, it has the weakness that it doesn't take into account the handling of heterogeneity, for example, in a patient, or in some cases, at least in proton therapy, you do not have the dose delivery at the recommended gantry angle, for example. And more importantly, log file-based patient-specific QA has found a use, and especially in proton therapy. And that is because modern machine, they log with very high frequency, millisecond or better, all the parameters that they are having for their relevant settings during the treatment. And you could check there, of course, after the delivery of the radiation, whether the machine could deliver all the important parameters of the treatment. For example, the right energy, or the positioning, at least in proton therapy, the position of a spot of protons in spot scanned therapy. And you could check those parameters against those recommended from the treatment planning system. And from that, you could assess the accuracy of the machine in delivering the dose distribution. Now, each of these, as I started saying, they have their advantages and disadvantages. Independent dose calculation mostly check calculation accuracy at treatment planning, and you have to complement it with a measurement of the delivered dose for the patient. And this is why measurement-based dose verification, they check the accuracy both from the treatment planning data transfer, so that the right plan has arrived to the treatment machine, and the dose delivery accuracy for the treatment machine. Log file-based patient-specific QA, they checks the accuracy of data transfer and the dose delivery. And this is something that is subject to very much research nowadays, is the combination of log file analysis with independent dose calculation in order to see what has been the predicted dose in the patient. This has also found advantages, for example, in adaptive trial treatment, where you could assess whether the intended dose has been given, and if not, to take some action, or if you see, for example, that the anatomy of the patient has changed significantly, that would adapt the treatment. However, log file-based patient-specific QA, it poses additional requirements on log data and data transfer. And then you have to do a QA that the log data is relevant, and the data transfer, for example, from the log file to your analysis system has been performed very well. Clinical studies. Nowadays, it's quite frequent that multiple clinics, they collaborate in the framework of clinical studies. And this poses additional requirements for quality assurance. An important part, for example, in order to get into a clinical study is the qualification and credentializing standards, where you have to, among other things, perform an independent beam output audit in order to prove that you could deliver the intended dose. This is actually something that should be also part of the general quality assurance program, because it checks the accuracy of your dosimetry system and could take out a systematic error that might have been overlooked. But then, in addition to that, there is a lot of standardization work, and the standardization work has to do with the delineation of the target of the organs at risk, and that is, for example, through dummy runs, where all the participating clinics are asked to delineate the structures to see that the delineation is done in a similar way. Treatment planning, that the plans have the same quality, again, dummy runs in treatment planning, and not in the least nomenclature. We are here medical physicists from many countries, and for example, if you are to refer to the lung or the heart, especially in an international study, you have to find a common nomenclature. Otherwise, you'll need to have data curation before being able to analyze your data. Last, but definitely not the least, is the quality assurance for artificial intelligence-based applications. Nowadays, we see artificial intelligence-based system applications algorithms, which touch upon the main steps of radiation therapy. Most of them are still part of research, but they are slowly going into the clinical practice. And here we're talking about AI for auto-segmentation, AI for image registration, synthetic CT generation, automatic planning, automatic patient QA, and even automatic machine QA. And what is common to all these applications is that the user has rather limited control over application performance. Most of the time, there is a phenomenological or a mathematical model behind them. It's not something that we physicists are used to. It's not a mechanistic model behind all these systems and algorithms. And therefore, what this means is that conventional QA techniques for non-AI-based system may not be valid for AI-based applications. So the recommended quality assurance in case of AI-based application is to look at case-specific QA, where you review the performance of the application output, either through human supervision. Nothing beats a human in order to see the performance. For example, if I'm referring to contouring, you have to have a radiation oncologist who overlooks or sees over all the delineations and correct them when needed. There are also some QA tools for automatic case-specific QA, where you look at parameters, and as long as parameters are within some expectation values, you should consider that it's okay. In addition to that, it's recommended to have a model QA that checks the model integrity and validity. And this is done by regularly testing and retesting the model to see that it provides the same quality. And if you have changes in protocol, especially if you have, for example, something that is based on images, if you have a change in the imaging protocol, if you have a change in the workflow, it's good that you have a new test set. And especially important if you're having an AI system that is continuously trained and validated on more and more patients, you could get to a situation when the testing no longer corresponds to the training model. And therefore, you have to be always on the watch on the performance of the system. And in this respect, it's quite important to have a performance log for your system where you check the number of cases in which you do not have enough quality on the output of the system, or for example, that the time needed for the correction of the contours, it's equal to the time needed to draw them from the beginning. Then you do not have, for example, a very good QA model for delineation. Other QA perspective, well, standardized procedures, they have helped very much in maintaining the standardization and even the quality. So it is recommended by several instances to have checklists to cover the various processes. You have to think about staffing and resources. Do you have the necessary competence in radiation oncology, RTP, medical physics, engineering, and IT? The training of this, they should understand how to use the system in a safe way and an effective way. Having a preventive maintenance program. You should not wait for your quality controls to show that you have bad values on something. It's very good, and it actually saves a lot of time if you have a preventive maintenance program, and not in the least the communication among staff. So to conclude, quality assurance reduces uncertainty and the errors in the various steps of the radiotherapy process, reduces the likelihood of accidents, and increases the probability that errors are recognized and rectified sooner. And not in the least, quality assurance allows a reliable intercomparison of results among radiotherapy centers. With that, I thank you very much for your attention.
Thank you so much, Alexander. This was a wonderful educational presentation that will be of benefit to many of our participants, whether they are junior or at the later years of their medical physics career. I would like just to remind people that the lecture is recorded and it will be uploaded tomorrow, so people can view the slides again because there was lots of information provided. We have had a number of questions in the Q&A session, Alexander, so if you allow me now to run the discussion. There are some perhaps clarification questions. Question about the 5% error. Can you confirm there was an inquiry whether that is the 5% error that involves everything in the chain, including treatment planning system, dose delivery, linear calibration? Is that correct?
Yes, that is generally regarded as the requirement in that is the overall uncertainty in those deliveries. So it includes the calibration of your accelerator, the uncertainties in the calculation, and the delivery of those to the patient.
So if we sort of assume that we sum up the errors in quadrature to get the final 5%, each of those individual errors should be less than 2% or something.
More or less, yes. In, for example, the calibration of your instruments, it's usually better than 1.7%. And if you determine that the output in reference conditions, you are better than about 2%. The calculation accuracy of your TPS, it's usually recommended to be about better than about 3%. And accuracy, sorry, the uncertainty in those delivered due to uncertainties in the mechanical or other parts of the system should be about the same order of magnitude. So overall in quadrature, you should be better than about 5%.
Exactly, thank you. Can you maybe explain, someone was not quite clear about what end-to-end check means?
End-to-end check means that you should go through all the steps of the radiation therapy process with a phantom case. So for example, you scan a phantom in your CT, you take that phantom to the TPS, you put a plan on it, you make a plan, optimize a plan on it, you transfer that plan to your OES, and you send the plan from the OES to the treatment machine. You use the imaging system to position the phantom in the beam and then deliver to see that all steps in the communication, they work smoothly, and then you have the right transfer of your parameters and plan parameters.
Would you call it also level 3 dosimetry?
Probably.
Yeah, and would you recommend to do it with rando phantom rather than a square phantom?
Definitely, because there you have the heterogeneity, there you have the structure to ensure the accurate positioning. So, and this is especially important, for example, if you put some markings on the reference point for the CT, and then you go to the isocenter treatment and you see that you have the right distances. So you also check the mechanical accuracy.
Exactly. How frequently should one check the CT calibration curves for the treatment planning system? And if there is a change in curve, what should we do?
Well, I'm very much biased now for protons, and we are checking them at every upgrade of the TPS to see that we do have the right calibration curve. And that is because they are very much related to range prediction. And we do not want to overshoot or undershoot when treating the target. So we always check and keep references on what is the recommended calibration curve, and at every upgrade we check the integrity. At every change in the IP, for example, we also check that the calibration curve is still there. And
I would also recommend
also
that
helps in being are we able to connect the calibration curve to the images that are taken on a CT scanner, on a particular CT scanner. That's another type of a check.
Yeah, exactly. I would also, if there is a significant change, redo the measurement just to ensure that there wasn't a human error.
Yeah.
That there suddenly was such a maybe big change in the CT calibration curve. How would you do in vivo dosimetry during radiotherapy? This is a complex question. I don't know whether
that's a complex question. Nothing is wrong with having a diode or something else or a transmission chamber to see what is the fluence that comes from the treatment machine. But various aspects of in vivo dosimetry, they check, various methods of in vivo dosimetry, they might check various aspects of dose delivery. For example, transmission chamber, they will check the fluence, they will check the output of the machine. They do not provide a measurement of, for example, swellings in the patient. They could help, for example, measuring the radiation that goes through the body of the patient, because then you see how much you should have gotten after the patient and how much you actually get. And there you see whether the positioning of the patient has been right, and also could relate it to the output of the machine. In proton therapy, again, that is not very much used because everything that you put into the beam affects the range of the protons, and in vivo dosimetry, it's not possible, or at least not at this stage. Possibly if we're going to have a fluence measurement, but that is very much in early development or research stage, so I should not.
There was another related question in regards to transmission detectors, whether those departments that use them, has there been a report that this led to the reduction in delivery errors? Do you have any data, or have you seen anything?
I don't have any data on that, but it's the principle. It's very good to ensure that the output is the same at every single fraction, not only when you check it. And it's especially good for those treatments that are employing a small number of fractions.
Exactly. Can you comment on the role on the QA of the equipment that you do QA with?
Sorry,
on the quality assurance of the equipment that you do quality assurance with? Well, for example, electrometer.
You have to calibrate them regularly to have a high quality instrument. It's very much recommended and stable. Also calibrating them regularly. So your ionization chambers, your electrometers, your thermometers, your barometers. So you need to have a QA on the equipment for QA, of course.
Exactly.
And it's equally important in ensuring the high compliance with the recommended dose.
In regards to, can you comment on QA in the era of adaptive radiotherapy?
Well, QA, it's QA. You have to perform it. You have to design a QA program that it's adapted to adaptive radiotherapy. And you have to check all the steps in the process and that you have delivered the dose. Very much discussion on the log file based QA. It's related to adaptive treatment. There is also the possibility of having very fast advanced calculations and independent dose calculations, because that will allow you to have the patient on the treatment table, imaging the patient, and then deciding whether to go on with the plan or you have to adapt the plan and do a real-time QA of the plan before delivery. But we are talking about a QA system that it's capable of checking the delivered dose in a matter of seconds, because otherwise you are going to ruin the advantages of adaptation. But exactly. That would have to be complemented by a very thorough machine QA, because you have to check many other parameters of the machine that you cannot really check in the delivery phase.
Alexandru, there was a question about the gamma criteria, gamma analysis.
Yeah.
And questions about its validity and whether it's sensitive enough, and it could be insensitive to
I think that's
clinically relevant errors such as DVHs, but it's
yeah,
still most commonly used method.
gamma
How can
analysis
we
is a
improve it?
very good method to check complex dose distributions. The settings of the gamma analysis, however, it's a little bit of a thorny issue because you should have some settings which will highlight your error cases. You do not need to have a lot of false negatives, if I could call them like that, where you have to check the dose and in the end you find out that you still had the right dose. It's also important not to let through, for example, very small hotspots in organs at risk, because that would be quite dangerous for the patient. And there are some studies that have shown that the gamma analysis is not a very good or a fail-safe method to detect all errors. So a gamma analysis would have to be complemented by your feeling of your experience as a medical physicist to check what are the implications of some hotspots or cold spots in your dose distribution. Even if you have a very high gamma pass rate, you should also check, do you have any hotspots or cold spots, and what will they mean? Where do they get? Are they in the target? A cold spot in the target is not okay. If it's a hotspot in a critical structure, again, is not okay. And you have to judge that according to, is this appearing in one field, but not in the other fields? Is this for a treatment with many fractions where you'll have probably some errors
Smearing of the dose,
and therefore you are spreading out that. So it's up to the experienced medical physicist to judge whether a small deviation is acceptable or not. But gamma analysis in itself, it's not a fail-safe method, I would say.
Yeah, okay, thank you. In regards to volumetric arc therapy checks, do you reduce the number of individual quality control checks?
I'm not sure I understand the question.
No, maybe if you have a 3D phantom, you are checking everything all at once. Will you reduce like ML? I'm not quite sure that I understand it. It's like, you know, I think people are a lot into optimization because with more complex treatments, we have more and more QA checks. Is there a way how to do a complex QA check more efficiently rather than individually?
One way would be log files. You deliver and you look at the log files and you look at the recorded machine settings during the treatment and you compare that with the requirements. And if they are okay, then you should assume that the treatment has been delivered okay. And that complemented with other controls would, for example, on the output, would give you the confidence that you have delivered the right dose.
Exactly, I agree. If physicists are perhaps, radiation oncology departments sharing equipment in other departments like radiology, what QA arrangement should be in place? I presume that would be medical physicists negotiating time with other departments to still do the same checks, yes?
Well, I'm not sure that I understand whether it's, for example, if you talk to nuclear medicine department, you should see that their images provide you the same geometrical accuracy, so that you know, for example, where the high activity are. It could also go the other way. If you have, for example, a treatment and if you have a hotspot, especially very early in the treatment, you might have an inflammation there. So if the patient would undergo a scan, you could share this information about where the hotspots are, but this is more about the workflow. I would say communication, transfer of the DICOM data between departments is quite important as well. Ensuring the positioning of the patient, but this is, I mean, rather obvious that if you are going to use nuclear medicine data or PET data, for example, for a patient, you should have the same type of radiotherapy flat top tables
Exactly.
during the investigation. It's again some sort of a QA, of course, to have the geometrical and the setup aspects the same in the both departments.
One last question. With the onset of the artificial intelligence,
Yeah.
what QA would need to be set up setting up a QA system for any AI-based systems? We now know that Varian sells an AI Linux.
Yeah.
We use AI for contouring in treatment planning systems.
Well, I had a couple of slides on that, and in principle, what you should do is check the consistency or how reasonable the output of the AI system is, either by human supervision, so you should have a trained human to look on it, but also to regularly perform QA on the AI system, either by regularly testing it, and
with a known data set?
On independent data sets. So you could try to see, for example, if you set it up, let's say that you have set up an AI model in the beginning and you have your testing set, repeating the testing set regularly to see that the model still maintains its integrity. However, the risk is that once you get into a step where you're using different images or your workflow looks differently, that the testing might no longer be relevant. So having periodically new testing sets might also help. But as far as I know, there is a lot of research on what is the best strategy to perform the QA of AI system or AI-based systems. Mm-hmm. But it's something that comes and will have to be prepared.
Absolutely, absolutely. Lots of scope for medical physics work for the development that come in this space. Alexandru, in the interest of time, I have to finish now. I would like to thank you very much for a fantastic presentation that's really cuts to the core of bread and butter of everyday jobs of a medical physicist. And this topic, I would like to remind our participants, will actually be extended in our next webinar on the 20th of June, which is still to be posted on our website, where we will have two speakers, one from AAPM talking about the QA of imaging systems in radiotherapy, and the second speaker from IOMP will be talking about patient-specific quality assurance. So we will dig deeper in some of those aspects that you have covered today. I would like to thank everyone for their attendance, and hopefully we can see you all again on the 20th of June. Thank you.
Thank you very much. Bye-bye.